Thank you, Mr. Chairman. I would like to thank the organizer, Professor Clavier and Professor Toso, for this kind invitation. I would like to thank Professor Hirose because I anticipated many of my slides, my concepts, so that my presentation is easier. As I said, Professor Hirose, HCC is not an exceptional indication because the prevalence of liver transplantation for HCC is increasing both in USA and in Europe. But there is a great ethical complexity when we talk about liver transplantation for HCC and for all organs. We can simplify this ethical complexity talking about urgency when we describe the risk of mortality before liver transplantation. Utility is the post-transplant outcome, recurrence or survival is the same. Transplant benefit is the difference between post-transplant survival and survival without liver transplantation. But the most important ethical principle is equity and fairness. We should use the same ethical principle for all patients in the waiting list. We could potentially use utility as a principle for prioritization. We have a lot of models to predict survival of HCC patients after liver transplantation. We have the San Francisco criteria, Metro Ticket 0, Metro Ticket 2.0, the 500 rule. We have a lot of models. And very recently, a group from USA proposed the HALT HCC based on tumor burden score, alpha-fetoprotein, and MELD sodium as potential criterion for priority in the waiting list. For example, you can see here patients without the tumor burden 0, very low alpha-fetoprotein, MELD sodium very low, high priority for liver transplantation. This is a controversial aspect. This is clearly patient too early for liver transplantation. And so if we use utility as priority criteria, we create an ethical paradox because we have patients without HCC stratified by urgency with the MELD score, and patients without HCC stratified by utility. And so we would have not equity in our waiting list. Another possibility is the possibility we used in USA now, an urgency masked prioritization. Urgency masked because, as Professor Hirose said, the MELD exception scores are arbitrary scores based on simulation models and not on real data. There were a lot of adjustments of this arbitrary score, but the most critical problem is the concept of MELD elevator, the scheduled progression of exception points every 3 months until liver transplantation. This masked urgency system has been developed in many countries worldwide, in Europe, in Brazil, and created a lot of problems. Problems mainly within the HCC population, increasing the disparity within the HCC population because you can see this system doesn't consider liver function. For example, patients with different biochemical MELD score have the same priority. Doesn't consider tumor characteristics. Patients with different tumor size and alpha-fetoprotein levels have the same priority. And the only factor determining priority is the time on the waiting list. This fact created a great heterogeneity in USA with different dropout and intention to treat survival in different regions in USA. Another problem is that waiting time on the waiting list has a controversial impact on post-transplant survival. Patients with too low waiting list time or patients with too long waiting list time have a worse post-transplant outcome. Another aspect is that this system has impaired the results of liver transplantation for HCC in USA. Patients in the recent years are higher waiting list dropout and lower post-transplant survival. Another problem is the problem of non-HCC patients. The non-HCC patients had a higher risk of waiting list mortality, and the HCC dropout risk is lower than that of HCC MELD score lower than 21. As you can see in these more recent works, the risk of dropout HCC in USA is less than 5%. The risk of dropout or death of patients without HCC is 25%. This is a great problem. Another problem is that of MELD inflation. This concept means that the higher the proportion of HCC in the waiting list, the higher the MELD score at the transplantation of patients without HCC. This is another great problem in USA. Some adjustments in last years, the delay 6 months policy, the cap HCC at 44, but all these adjustments are thought to improve the situation of patients without HCC. None of these adjustments are thought to improve the selection, the priority of HCC patients. We have also some proposals in the literature for real urgency-based prioritization systems. We have some system in Italy and Canada more recently. These are arbitrary scores, but accounting for tumor characteristics, where have been prospectively applied in real world, but are applied on small cohorts of patients, and some variables have not been considered in these scores. Other interesting scores, the most interesting are the last two, that from Christian Toso, the dropout equivalent MELD score, and that from USA, Marvin, the MELD equivalent score. You can see here the formulas are complete scores because they consider the biochemical MELD of the patient's alpha fetoprotein, number, and size of the tumor, are equivalent in terms of predictive ability. But these systems are unbalanced toward urgency in terms that compromises utility of liver transplantation. For example, patients with a high value of alpha fetoprotein have a high dropout risk, high priority, but they have also a higher risk of post-transplant recurrence. But the other important thing is that this system have a C-index, a predictive accuracy of about only 1.65, while the predictive accuracy of the MELD score is above 0.8. So there is a problem of accuracy that is very important. A last potential principle is to use the transplant benefit as prioritization tool. As you know, transplant benefit is the difference between survival after liver transplantation and survival without liver transplantation, is the area between the survival curves. The advantages, potential advantages of transplant benefit is that it combines urgency and utility. As shown by Schaubel in his historical paper, maximize the overall survival of all patients in the waiting list. And most importantly, MELD score is a strong predictor of transplant benefit. So there is the concrete possibility to create a common scale between non-HCC patients and HCC patients. We have introduced this concept of transplant benefit also for HCC patients, and this concept has been introduced in the real life in Italy in our guidelines to select patients for liver transplantation. So patients with the highest survival benefit are patients with advanced cirrhosis and HCC, patients with a good response to downstaging or extended validated criteria in the intermediate stage. But patients in the early or very early stage are the patients with the lowest benefit. So these patients are included in the waiting list only if they have a recurrence after a first-line treatment. We have also tried to introduce a MELD equation based on transplant benefit. This equation gives a high value to the biochemical MELD score of the patient with HCC. As you see, alpha-fetoprotein has a negative effect on transplant benefit. The limit of this system is that it's based only on T2 patients, so some tumor characteristics and the response to therapy are not considered in this system. But we have performed another study calculating the intention to treat survival benefit in a large European cohort. And here you can see some behavior of some important variable for HCC. For example, low MELD score is a negative factor for survival benefit. Milan out criteria have a higher benefit because they have no alternative treatment, only chemoembolization. But alpha-fetoprotein has a negative effect on transplant benefit. Another interesting thing is that patients with complete response to therapies have a low benefit, while patients with a progressive disease after local regional therapies has also a low benefit. And this system has been incorporated in the Italian allocation system with some arbitrary, obviously. In the current in use Italian system, we have a response to therapy. Patients with downstaged or with partial responders to bridge therapy have the highest priority. In second position, patients with first presentation or late recurrence. Patients T1 or complete response to all therapy, not only to resection, but also to local regional therapy, have only biochemical MELD score as a priority. We have also the HCC MELD formula giving a higher value to the biochemical MELD score. We have some arbitrary extra points to increase the priority of the patients. This is a negative aspect that we have to modify according to my opinion. And there is a cap at 29 to not penalize the patients without HCC. So in conclusion, according to my opinion, we can't solve actual problems also in allocation by using the same kind of thinking we used when we created them. So I think that is not possible to adjust a system like that of exception points, continuously adjusting it. But we have to change the paradigm. I think that transplant-based benefit is a potential good tool to change priority in HCC patients. Thank you for your attention.